Hello, good morning. Welcome everyone to today's monkeypox Q&A session. My name is Julio Fonseca. I use he, him pronouns. Thank you for your patience as we addressed some technical issues that we were having on Zoom. Hola, buenos días, bienvenidos a todos. Me llamo Julio Fonseca, uso el pronombres he y él, y gracias por su paciencia mientras solucionamos nuestros problemas técnicos en Zoom. I will turn it over now. You should see a slide that can show you how to access the interpretation services, and I can turn it over to our interpreter to provide that information in English and Spanish. For folks that are listening to the English channel, our interpreter is on the Spanish channel explaining how to access the interpretation there. Si necesita los servicios de interpretación, I'll do it in English on the English channel if folks are on the English channel. If you need to access the webinar in Spanish, you can follow the little globe that's at the bottom of this slide. When you hit that globe, you'll have the option to select the English or the Spanish channel if you need to select the Spanish channel. También las instrucciones están aquí en el slide. Si necesitan los servicios de interpretación en español, hagan el clic en el globo y selecciona el canal español. And I think with that, we can get started. So thank you so much, everyone, and welcome again to the monkeypox community Q&A. Our partnership with Building Healthy Online Communities is supported by our Partnering and Communicating Together initiative at AIDS United, where we work to with partners to innovatively disseminate information on Let's Stop HIV Together campaign, which has the hashtag Stop HIV Together, to communities on HIV education, prevention, treatment, and stigma reduction. Again, my name is Julio Fonseca, and I'm with AIDS United. I use he, him pronouns. We're excited to be here today, and we are showcasing monkeypox because of the intersections of the communities that are currently impacted by monkeypox and communities that are living with and vulnerable, to HIV. We're super excited to hear from our panelists and also from community. We know that for various reasons that information and understanding on how people acquire, prevent, and treat monkeypox have been challenging to access. So we're very happy to be able to provide this forum for folks to not only have their questions and concerns addressed, but to also feel like their voices are being heard. And we can go to the next slide. So this is just our quick agenda, and I had sort of touched upon it. We've got some really fantastic panelists who each bring their lived experience and other experience to this discussion to talk about, treatment, vaccine, and other updates, how to deal with monkeypox stigma, as well as navigating safer sex in the midst of monkeypox, and how communities who are interested in learning more about supporting the monkeypox response can get involved. We think that I'm sure that folks have questions already that they're looking to ask. One of the things that AIDS United is committed to doing is capturing all of the questions from today. We know we may not be able to address all of them in the webinar, but we look to provide additional answers to recipients after the webinar. And next slide. So what is the current state of monkeypox in the United States? The data here are from most recently from what has been reported as of August 18th, which is a handful of days ago. Keep in mind when you look at this map that these are reported and known cases of monkeypox. So the data could be quite different based on whether or not people are aware that they have been exposed to monkeypox or that they are experiencing monkeypox. While this data tells a partial story, it does tell a very compelling story about where we're seeing monkeypox across the domestic United States, and also the communities that are being impacted, that we're seeing the impacts of monkeypox in first. Predominantly cisgender men who have sex with men, as well as their sexual networks. As is unfortunately often the case, the data on how these are impacting people of trans experience and people who identify as non-binary are very limited. Let's look at the next slide. So where are the intersections of monkeypox and HIV? I think that we've seen that communities and organizations, and agencies and public health entities who engage with communities who are living with or vulnerable to HIV are often called upon first when there's a new public health epidemic that impacts those communities. We've seen it most recently with the ongoing COVID-19 response, and how many AIDS service organizations and other providers pivoted and built upon structures that they had in place to address the HIV epidemic, to address the COVID-19 response. We're seeing in this slide, there are several examples of reactions and community reaction to the current domestic response to monkeypox. As a person who has been living with HIV since 2009, who also works in HIV, I haven't had to look too far back in our country's history to see where, lack of meaningful community-focused response to the, HIV/AIDS epidemic in the 1980s led to very catastrophic losses in communities where, HIV was first occurring, specifically gay, queer, bisexual, and other identified men who have sex with men. And so it feels familiar in many respects for some of us who are living with HIV and who have lived through the COVID-19 pandemic, who are now experiencing this less than optimal response. It personally feels a little disappointing to feel a part of a community that is yet again being othered in terms of meaningful response to a public health crisis, and also seeing how we as community are coming together, in urgency to generate urgency and response again. I think that we're very fortunate to have blueprints and guides for how to galvanize community, to share information, to share education strategies, and to advocate for stronger, response. But I think most importantly, to take care of each other. And we stand on the shoulders of many who came before us, and we have the opportunity to take their examples on how to care for the communities that we're a part of, those who we directly provide services and care to, and those who we intersect with today. And hopefully today, this Q&A continues to sort of be a light and a guide on those roadmaps on fostering how we can continue to support each other and empower ourselves with information as we navigate monkeypox. So with that, I will stop talking. We can go to the next slide. And I will turn it over to our first panelist, Dr. Oliver Bacon. Oliver, would you like to take a moment to introduce yourself and give us your pronouns and tell us a little bit of background in terms of what has brought you to us today.
Right. Thank you very much, Julio. My name is Oliver Bacon. I use he, him pronouns. I'm an infectious disease doctor. I have spent much of my, I guess, 20-year career doing HIV care and treatment and prevention. And about 5 years ago, switched over to being the supervising physician at San Francisco City Clinic, which is the San Francisco Department of Public Health STI clinic. I would say since the beginning of June, we have been basically a monkeypox clinic that also sees people with STIs. That gives you a sense of the impact of monkeypox on San Francisco, as has also been happening in New York, Chicago, Miami, Los Angeles, a number of Canadian cities, Montreal, Toronto, and cities in Europe. And that is without even mentioning the countries in Western and Central Africa where monkeypox is endemic. We have, because this outbreak of monkeypox, the one that emerged to people's attention in the West in May 2022, is really affecting men who have sex with men and trans people who have sex with men, and is presenting with many features of a sexually transmitted infection, and indeed is being sexually transmitted. STI clinics are very, very much in the forefront of diagnosing and treating people with monkeypox. So I'm going to give a little bit of background overview on monkeypox and what's different about this iteration of it from previous ones, and then spend a little bit of time on vaccines and treatment. Okay, so some monkeypox basics. Monkeypox is a member of the orthopox virus family. Its more famous and nefarious sibling is smallpox, which was eradicated globally through a mass global vaccination program that ended in the 1970s. Smallpox has a mortality of 30%. Monkeypox has a published mortality of 1 to 11%, depending on where you're living and what strain you're infected with, and also what your underlying health conditions are. The name monkeypox is really a misnomer. This is a virus that really prefers to live in rodents. It's called monkeypox because it was first isolated in a colony of research monkeys in the late 1960s. The first human case was in a child in the Democratic Republic of Congo, at the time Zaire, in 1970. As I said, the reservoir is generally in small rodents, typically, historically, in endemic countries. Transmission has been from rodent scratches or rodent bites to humans, with very limited human-to-human transmission, usually within households, and usually with a very short chain of transmission, maybe maximum 4 people. And in general, it's a self-limited viral illness, although it takes up to a month to resolve. People who are historically at increased risk of serious outcomes were those under 8 years old, people who were pregnant, people who had diffuse skin conditions such as eczema or psoriasis, and people had underlying immunosuppressive conditions that were taking immunosuppressive medications. You may have heard that there are two strains of monkeypox, the Congo Basin strain and the West African strain. Those have been renamed recently as Clade 1 and Clade 2 to get away from geographic stigmatization. Clade 1 is more serious, least more serious disease complications. Clade 2, less so. And we are very fortunate in that Clade 2 is the strain thought to be responsible for the current 2022 outbreak of monkeypox. Okay, so jump to 2022. Very, very different epidemiologic and biologic behavior of this virus. So in May 2022, multiple outbreaks of monkeypox were noticed in men who have sex with men and trans people who have sex with men in Western Europe and then very quickly in the Americas. These were multiple concurrent outbreaks, which is not the way monkeypox has historically behaved. These were associated initially with attendance at sex parties, raves, bathhouses, but very quickly transitioned to community spread within MSM and trans-SM sexual networks. The manifestations have been quite different than what is usually written about historical monkeypox outbreaks, in that many, many people presented with anogenital lesions first. Very interestingly, this was presaged by a 2017 outbreak in Nigeria in networks of cisgender men who had a lot of sex partners. It's not clear what gender their sex partners were necessarily, but they also presented with anogenital lesions. And so there's some speculation that the virus may have changed to some degree to prefer mucosal spread versus airborne respiratory spread. But also that it landed in the right sexual network. So there's some combination of possible biological change in the virus and finding routes of transmission among humans that it had not previously landed in. Okay, so a couple of other differences between our current outbreak of monkeypox and previously. So in the past, there was a very stereotypical progression from infection through a 2-week asymptomatic incubation period during which people were not thought to be infectious, followed by a short prodrome, sort of like the flu, fevers, headaches, swollen lymph nodes, body aches, and then very quickly the development of skin lesions, first in the mouth, then on the face, then on the extremities, the arms and legs. These would proceed from spots to bumps to pustules, and which would then slowly over 1 to 2 weeks crust fall off. And you were thought to be infectious from the onset of the febrile prodrome until the last lesion had fallen off and been replaced by new skin. What is different now is that everything is a bit jumbled. The incubation period is much shorter. It's on average 7 days. This is from a very, very good study from the Spanish outbreak in May 2022. Many people do not present with the prodrome. They go right from incubation period to skin lesions, although some people have the prodrome. And in fact, the order is kind of jumbled. Some people get their skin lesions first and then have the febrile illness. The vast majority of people have anogenital lesions first that then may spread to the head and then to the extremities. We've seen very, very unpleasant cases of proctitis or inflammation infection of the anus and the rectum, very, very painful lesions on the head of the penis, particularly in people who are uncircumcised, with a lot of penile swelling, difficulty retracting the foreskin. And also we've seen cases of very painful infection in the posterior throat, in the back of the throat, that make it difficult to swallow. We've also seen cases of very, very mild disease, 1 or 2 lesions, nothing else forms, they dry up, they fall off, and the person is fine. So there's a wide spectrum of disease presentations. Okay, so treatment and vaccines. So the treatment and the vaccine for monkeypox were developed for its more nefarious cousin, smallpox. and largely in preparation or in fear of a potential bioweapons event involving someone getting their hands on a stock of smallpox and releasing it. Smallpox vaccination historically used a live attenuated version of the vaccinia virus, which is another orthopox virus. Vaccination with vaccinia conferred very substantial protection against disease with smallpox. And that is the virus that was used to vaccinate the world, basically ending in the 1970s. At the time, the risk-benefit ratio favored the use of live attenuated vaccinia virus called Dryvax because smallpox was so deadly. The vaccine itself is not, has some side effects and is not safe for use in immunocompromised people. So a safer version was created about 10 to 12 years ago called Jynneos or Imvimune. It is a non-replication competent vaccinia virus. It doesn't really have much in the way of side effects. Its efficacy has never been studied in a true human vaccine trial where you have people who are at risk of disease, you vaccinate half of them, you don't, or you placebo the other half, and then you count cases.
Oliver,
We've never done that. Yes.
can we give you 1 minute to wrap up? Thank
you.
So
the vaccine that we're using now has not been tested for efficacy, but we think that it provides some protection, and certainly with the first dose. The medication we're using right now is a medication called TPOXX or tecovirimat. Again, this has never been studied for efficacy in humans. It's been studied for efficacy in monkeys with monkeypox, rabbits with rabbitpox. It has been studied for safety in humans and is a very, very safe medication. And we're using a lot of it in San Francisco. I'll wrap up now and we can talk more in the Q&A session.
Thank you so much for the overview. I know that there's probably going to be a lot of questions about the treatment because it's something that folks haven't heard as much about. So we look forward to the Q&A. I'm going to move to our next panelist who folks may recognize. Brian Thomas is a registered nurse who's living with HIV, who discusses affirming sexual health on TikTok at PausRN and also on Instagram at Pause Nurse. There's some additional resources that are being put into the chat about TPOXX and the intradermal shot, so feel free to take a look in the chat as well. But super excited to have Brian here today to talk about monkeypox stigma and safer sex. So Brian, if you want to introduce yourself and your pronouns and take it away.
Hey, thank you so much for having me. My name is Brian Thomas. My pronouns are he, him. Yeah, I has started my social media platform years ago to promote, destigmatization of HIV as a healthcare worker. And it just kind of tracked that when I got monkeypox, that I could use that following that I already had to make a really big difference. And so I did, and I was, one of the first, I was the third person in Maryland to be diagnosed with monkeypox. And at the time, no one knew what to do. My providers had no idea how to treat me, what to tell me. They knew to tell me to isolate, and that was about it. And, I documented that whole adventure on social media. And, stigma is so alive and well, especially with monkeypox. And I think it really just comes with there being this new disease. And we had a lot of early media exposure that really stigmatized the MSM and TSM community. And it's still, media sources have now changed their tune, and now they're not including the community at all in their message, which is like, we have these two polar opposites that we need to find a happy medium, because with public health information, we need to make sure that we are targeting the at-risk population, which we know what that is, but we also have to really be careful not to stigmatize those demographics. So we had a lot of early media exposure that said, oh, this is being this is mostly affecting this community, and this is how it's being spread at bathhouses and sex clubs and through high risk sex. And that really stigmatized the community. And then when it came to even the vaccine rollout, I know here in Los Angeles, the questionnaire to qualify to be to get the vaccination here, one of the check boxes was, you have to be HIV positive or on PrEP or have had multiple anonymous partners or had sex at a sex club or bathhouse, right? So basically they're saying to get this vaccination, you have to be HIV positive or on PrEP or be a hoe. And it was extremely stigmatizing. And I think we're still seeing those messages. And it all comes down to this idea that, yes, we essentially have this new STI, which that's predominantly how it's being spread. And it's really easy to make this about slut shaming and about, and to be a moral disease, which it's not. And it's really important to convey this message that anyone can get this illness from one intimate encounter from any person of any gender. It's predominantly within the MSN and TSM community right now, but no matter what, diseases do not discriminate. If you are in intimate contact with someone else who has monkeypox, no matter who they are, you are at risk, right? I personally think it's very important to convey a complete message when we're talking about this. And I think that goes back to the basics of reducing stigma, using correct language, using accurate information about illnesses, and then also speaking out in public, on the media, on social media, when you hear something or see something that is wrong. These are just like a few ways that we can start to break this stigma, because it started that way and it's continuing to really stigmatize the community so much that people, I got a lot of media attention when I came out as monkeypox positive, because nobody wanted to talk about it. Nobody wants to admit that they have it, because it is this widely kind of understood that, oh, you must have been having risky behavior or have lots of sexual partners to get this illness. So people that are getting monkeypox, they don't want to talk about it. They don't want to share it with their friends. They don't want to call their partners because of that stigma. So the more we work to reduce that, talk about it openly, communicate, I think the better it will get as far as reducing stigma for Mpox in the community. And the other topic that I love to talk about is sex, obviously. And, how can we have safer sex? How can we participate in sexual activity in this outbreak of Mpox? And I take an approach that sexual health is on a spectrum. And on one side of the spectrum is complete abstinence. And obviously that's the safest way that you'll prevent this illness. But abstinence isn't a possibility for a lot of people. And I think it's important that we understand that. And we understand that the other side of the spectrum is a sexually active person. And how can we implement ways to reduce risk while still having a fulfilling sexual life? So there's lots of ways. We have abstinence, which if you can abstain or reduce your partners until you are fully vaccinated, that is great. If you can't, start with the most restrictive or contactless sexual encounters as you can, and then move in the other direction. And it's important for every person to weigh the risks and benefits of every act that they take, being intimate with someone, and what risks are you willing to take to give yourself the most fulfilling fulfilling sexual activity for you.
Brian,
Sexual health, yeah.
can I give you 1 minute?
Yeah, absolutely. Sexual health looks different for every single person. So just really weigh those risks and benefits for you. Go get vaccinated. I think that's the primary thing that we can do to really reduce risk and reduce spread. And other methods are things like reducing actual skin contact with people you don't know, reduce your amount of sexual partners. If you have multiple sexual partners, possibly have a smaller group that interacts with each other, so that you're reducing those kind of outside risks. Things like barriers could be an option. I am a kink positive person. I'm a full advocate of full latex garments. Those could be very helpful. So there's lots and lots of different things that you can do to reduce your risk. And my message is just to make sure you figure out what's best for you. If you look at my my little bullet points, I think one of the most important things that we can remember to reduce risk is when someone tells you that they have Mpox, avoid your curiosity and don't ask them where or how or who they got it from. It's really stigmatizing. We know how it's spread right now. And when the media asks me, I'm like, do you want me to tell you I got it at a bathhouse having sex with multiple partners, or do you want me to beat around the bush? So just stay away from that question. It doesn't matter unless you're involved in contact tracing with a patient. It's not your business. So awesome. Thank you so much for having me. It was really, really been a pleasure.
We're super happy to have you, and we're looking forward to some of the questions that get to your bullet points as well, and some of what you brought up today. So thank you so much for that. We are moving to our third panelist, and we can also move to the next slide. Cecilia Gentili is the founder of Trans Equity Consulting Incorporated, and worked in collaboration with Callan Lord to found the COIN Clinic, a free healthcare program for sex workers in an affirming and supportive environment. Super excited to have you here today. If you could take a moment to just introduce yourself and share your pronouns, and kick off this part of our discussion.
Of course. Hola, everybody. I hope you are doing well. My name is Cecilia Gentili. I use gender pronouns she and her. And I'm sorry, my voice is acting a little bit weird, but I'll try my best. So yes, I live in New York City, and here what I'm gonna do today is talk a little bit about the response, right? So I am going to become of a little bit of that mad lady that is going to complain about the government, because needless to say, the response was really poor from the government and from the Department of Health. And unfortunately, we have had many vaccines stored for many years that didn't work anymore after a while. And the government, during all those years, didn't think about rolling any kind of vaccinations, because nobody thought that this would, become a health emergency in the country, and for that we lost a lot of vaccines. Then we had an incredible number of vaccines in Finland that did not find their way to the United States due to, we don't know why, but the government didn't send them. So I know it sounds like I'm complaining a lot around the government, because, again, the response was really poor. and we should have much better prepared for these. So when it comes to the rollout of the vaccination, it has been different in different places in the United States. But here in New York City, for example, it was when Brian was talking about the criteria, right? He didn't mention, or maybe I didn't get it, but the first criteria is that you had to be either a man or a person who was assigned male at birth, right? So anybody that was not assigned male at birth was not able to get this vaccination, right? So that leaves, in my case, and around the work that I do, that leaves a huge community that is at risk. That is, for example, sex workers community, right? So let's think for a minute about massage parlor folks, right? Whose job is basically called body rub, which means that they're rubbing their bodies against the ones of the people that are serving, right? So what could be more important than take care of people who are rubbing their bodies as their job, right? Let's think about escorts of all genders, right? What about if sex is your job, right? And you are not able to stop working because you have to pay rent or you have to eat, right? What happens to these folks, right? It's a very terrible situation. And we went through the same thing with COVID, right? Where everybody was like, stay home, don't meet anybody, right? And be safe. But what happened if meeting people is your job, right? What happened if being in close contact with people is your job? So sex workers have been left out of this response, and that is very worrisome. Let's remember that, for example, in New York City, me as a person who worked in the sex trade for so many years, most of my clients came from other places in the country, right? So they would come to New York and they would take the opportunity to see a sex worker that would engage in the sexual behaviors that they crave, and they couldn't get whatever they need. So that's how exposure has been a lot of times being traveling from places to places. So I believe that the response of vaccination has been really poor around sex workers. As Dr. Oliver and Dr. Bacon and Brian mentioned, it was like a very stigmatizing around the behavior, right? But it has also been very stigmatizing around gender, right? In my case, as a trans woman, I had to disclose to everybody several times. I did it in a pre-screening, which is okay because I did the pre-screening at home, right? But then when I got to the vaccination side, I was in a room full of mostly I perceive cisgender men. And we were in the same very small room and everybody could hear everything. And I had to disclose that I was assigned at birth, that I identify as a transgender woman, that I'm sexually active. All of these things that in my case, I don't have a problem doing. I'm very open about, my gender and my sexuality and my body parts. I don't care. But for many of my friends felt a little bit overwhelmed of having to be disclosing in places all information that nobody should have to disclose, right? And it wasn't that they were like screaming it to everybody, but the spaces were very small and everybody had to hear all those things. So when it comes to the response, what I can say is that unfortunately, we did not have the most responsive approach.
Cecilia,
Yes,
can I give you 1 minute?
you can give me 30 seconds. And we did not have the most comprehensive approach, and we hope that we can learn from those errors and move on, because unfortunately these things happen and they're not going to stop happening. So thank you.
Thank you so much. Folks, there are resources that are being put into the chat, and we can, AIDS United is also keeping a document of questions so that if there are any that we don't get to, we can get those resources out to participants. We will also ensure that the resources that are shared in the chat are included as well. We are super excited now to move into the Q&A portion of today's webinar. And if folks do have questions, we ask that you use the Q&A function as opposed to the chat function, because sometimes things get buried in the chat and we want to make sure that we're able to really address and make use of the time that we have. I think, is there a next slide? Or, all right. So it looks like I can go ahead and read off the first question that's in the Q&A, and that is from Donald H. And the question is, what is the difference from the original dose of the Mpox vaccine and the new way of 5 doses per vial?
Sure, I'll take that one. So the way the vaccine was studied was 2 doses, 28 days apart, given subcutaneously. So basically into the fat, sort of the needle goes straight into your arm, sort of, or you can see like boom, like that, okay? Because of the shortage, vaccine, it's now being allowed, and in fact, in some places required, that you give a smaller dose intradermally, meaning you slip the needle in along the skin, just under the surface, because that is a very immunogenic part of the body. There's a lot of antigen-presenting cells, parts of the immune system that really respond very quickly and forcefully to infections or immunizations. And this is why in the old days when you would get a TB test, it was an intradermal test. You'd slip the needle just under the skin, raise this little bleb, and that would very quickly let you know if your immune system had seen TB before. Same thing with the Jynneos vaccine. You can use 1/5 of the dose, but delivered in a slightly different way. And it's thought that that is as immunogenic as the full amount given subcutaneously. So it's a way to stretch out the vaccine doses. And there is some experimental evidence that the immune response as measured by antibody levels and cellular response to this vaccine given intradermally is pretty equivalent to the immune response when it's given subcutaneously.
Thank you, Dr. Bacon. I just want to highlight in the chat, thank you, Jen, for sharing, that AIDS United has a webinar on the new intradermal strategy that is at that YouTube URL. I'm going to kick things over to Emmett Patterson with Building Healthy Online Communities to continue the Q&A portion of the webinar. So, Emmett?
Absolutely. Hi, everyone. My name is Emmett. I use he and him. And I think that there have already been some really good questions in the chat, really about that are related to this rollout, not quite fitting the way that a typical vaccine schedule would look like. So I do want to really kind of give some time to this particular question, which is about when is it safe to have sex again? I think we can talk about, while you're waiting on a second dose of Jynneos, and also this person is asking after you've had monkeypox and isolated. So I think Dr. Bacon, maybe we'll throw that over to you. And then maybe Brian, if you have some kind of more specific tips on some of those harm reduction practices, I'd love to hear those as well. So Dr. Bacon, when can folks have sex with some peace of mind?
Yeah, boy, I wish I could tell you a really clear answer on that with loads of good evidence. As you can tell, I can't. So think about the way it's transmitted, right? So definitely skin-to-skin contact with lesions, absolutely high probability of transmission. The viral load, so to speak, of these lesions in these skin lesions is much higher than in the back of the throat, for example. We don't yet know about rectal secretions. So definitely, I would wait until all of the skin lesions have fallen off and been replaced by fresh skin, okay? So that's one thing. The real question is, do you still have virus that's infectious once that has happened? And we don't have a good answer for that. Let me rephrase that. Viral DNA has been isolated in semen after people have recovered from their skin lesions. Is it actual virus? Is it replication competent virus that can infect other people? Is it just remnant DNA from dead virus that's hanging out? We don't know. How long is it there? It's only been studied out to, I think, 20 days at the most. Is it still there 12 weeks later? We don't know. How long is it in your respiratory secretions? We don't know, although it really looks like in this current 2022 outbreak, and I may regret saying this in a couple of weeks, but respiratory transmission seems to be less a factor than skin-to-skin or mucous membrane contact. So in the UK, they're recommending up to 12 weeks of condom use after you've recovered from your skin lesions. We're actually recommending that in San Francisco, although that 12-week time limit is pretty arbitrary. I haven't found any source for that particular recommendation. It's extremely cautious. The second part of the question is, how much protection does the vaccine confer? Again, because the vaccine has not been studied in a traditional vaccine efficacy study, we don't know. What are called correlates of immunity are very promising. You get a good antibody response, you get good T cell and B cell responses 2 weeks out from your vaccination. Does that protect against transmission? We don't know. So I think really, I agree 100% with Brian that, everyone has their own tolerance of risk, right? And I think equipping people with usable information about how it's transmitted, what we know and what we don't know about what's infectious and what's not in terms of body parts, lets them decide what is safe based on their own risk tolerance. That's how I would put it. I would encourage everyone to get vaccinated because it's going to provide some degree of protection, even though we can't say exactly how much. And I would probably leave it at that.
Thank you for that. I did see, before I kind of throw it to Brian, I think that there is some concern from folks in the community about this 1/5 dosing strategy. I'm wondering if you could kind of clear up a little bit about some of those concerns, especially I know folks have been confused about seeing a wheel, which is kind of like the the fluid of an intradermal vaccine after it's been done. There's definitely some concern about vaccine providers not being trained up in doing intradermal and potentially doing subcutaneous instead. You know, what kinds of messaging have you seen at that larger public health level about this strategy, and you know, where folks can get more information on what to look for post intradermal vaccine? I would say, Dr. Bacon, that's probably over to you a little bit.
So what the question is, what degree of protection are we getting from the intradermal vaccine, or is it more about issues surrounding how to give it?
I think it's a little bit of both. I think there's been concern from folks about, you know, are there particular signs I should look out for that the vaccine was given to me properly intradermally, and you know, how can I, if I don't see those, what do I do?
Yeah, exactly. So what you should be looking for is a little button in your skin. Like if it's properly given intradermally, it's going to raise this little dome. Okay. If you don't see that, then it probably wasn't intradermal. It was probably subcutaneous, and what you've then gotten is an insufficient quantity of a subcutaneous dose, right? So you want to see, as it's a little bit uncomfortable, I'll tell you. It's a very skinny needle. As the dose goes in, you should see this little bump appear. It looks like a little button under your skin. The other thing about intradermal dosing is it will remain irritated for a couple of days. Whereas I think anyone who's gotten a subcutaneous Jynneos vaccine, it doesn't feel great. It itches a little bit. It feels a little weird, but it's like any other vaccine, basically. The intradermal one, it'll be irritated for a couple of days afterwards. So you actually want to see the button, and you want to feel a little bit at the site.
Yes, I feel very about a lot of what has transpired in the last 2 months. But thank you for that. I know that was going to be a big kind of question. And again, we'll send it out in the notes that Agent did do a webinar on intradermal strategy, and please be on the lookout for more information coming for what to expect. But Brian, I actually did want to throw it to you for a second, talking about, I know at Building Healthy Online Communities, we've also been struggling about how to talk about safer sex as it relates to where you're at in the vaccine schedule. You know, if you've got, we know it, you know, from the research, we know what happens, you know, 2 weeks after Jynneos, like you're going to be the most protected. But a lot of us are now currently, you know, in limbo waiting for our second vaccine. So I just kind of wanted to throw it to you, Brian. You know, what are some of the ways that folks can, you know, practice harm reduction, you know, while they're waiting around for that, for more protection to come from that second dose?
Yeah, sure. I mean, I think it's also important to include the information that, as Dr. Bacon said, like, we don't have data on the efficacy of this vaccination when used for monkeypox. There is none. So we have expectations that it should give us resistance. We have expectations that after the second dose, 6 weeks into your vaccination schedule, and it is the first dose 4 weeks, the second dose, and then 2 weeks after that is thought to be the best efficacy of the vaccination. We don't have those numbers, and I saw a question about, should we still be changing our sexual health habits even once we're vaccinated? And the answer is absolutely. If you can, I think until we have more data, if you have the ability to change your sexual health habits to curb spread, I think that is a great option. And again, like I'm always kind of preaching is that it is a risk and benefits kind of determination for you, right? So, you know, if you can dial it back, if you can abstain, awesome. If you can't, you know, the next most restrictive like way that you can engage in sex is having online sex, having video sex, having you know, mutual pleasure through technology. That is an option. You know, and going from that, you can have sexual encounters where you actually aren't touching your partner. You can be in the same room and be talking dirty and pleasuring yourself in the same room with that person without actually engaging in skin-to-skin contact. You know, from that, if you are engaging with intimate skin-to-skin contact with a partner, if you have one partner that say you're married and you have sex with one partner, obviously like your risk is very low. So go ahead and have as much sex with that partner as you want. I mean, if you're not married or whatever, that's one partner. And then if you have multiple partners, having a really solid line of communication with that partner and how many partners that they have, that's incredibly important. Knowing the people that you are engaging in contact with and knowing how they practice their sexual health will be really, really important in being able to judge your risks in engaging in intimate contact. You know, there are garments, there are kink garments that cover your skin completely that you could absolutely wear, which will reduce your chances of skin-to-skin contact in general. There are, you can use barriers like condoms, and latex barriers and things like that. They could reduce chances of transmission, but we are not sure of that. We know that this virus really, really loves the mucosal area. And we also know that it loves just skin-to-skin contact. So barriers, if you can implement them into your practices, that'd be great too. If barriers are not part of your practices, you can, you know, divert back to communication and frequent testing, keeping an eye out for symptoms, getting vaccinated. You know, these are all things. If you are going to be active and intimate with multiple partners without barriers, the things that you can do are getting vaccinated, frequent testing, keeping an eye out for symptoms, communication with your partners. If you have anonymous sex, then you can implement some of these. So I mean, these are just the multiple ways that you could implement these tools to reduce transmission and find the right ones for you. I think that's super important.
Absolutely. I think as a person who's immunocompromised and still very much affected by the COVID pandemic and how the COVID pandemic has affected my sex life, there's been a lot of crossover for trying to figure out what are some of those things that I can still do and still like have pleasure with. So thank you for just kind of giving us some ideas. And I also appreciated in the chat, there was somebody who was saying, figuring out your own kind of risk, you know, and it's not even just risk, but it's like, what do you want in this moment? And I think it's not just a one person, you know, it's not a one-sided thing. This is also a part of consent. I think if you remember some of these amazing guides, like the Quarantine Pod checklist for COVID that came out, you know, really talked about be blunt with what you're doing and who you're doing it with. There have been great folks who've been recommending setting up pods where you all kind of, you know, share like, you know, kind of the same spaces. Maybe not everything. Some of us are a little, you know, selfish in a good way. But there's definitely a lot of ways to still get what you want without, you know, kind of this, you know, threat of abstinence hanging over you. I think that that's something that really has angered me, because often it feels like that's there and then there's no help coming from, you know, that federal level or even at the local level. So just wanted to highlight that in the chat. We do have two questions here, and Cecilia, I think this kind of goes to our conversation yesterday that we were having, is that as usual, you know, trans folks, we are not included, thought of, centered in this response. And often it leads to us having to disclose, or in my case, you know, having to lie about my sex assigned at birth because I knew I was at higher risk. So I definitely want to talk about kind of that, the invisibility that trans folks have been, and as well as I think somebody else also asked folks who have occupational exposures, whether that's through sex work or working in another kind of high risk place. So, you know, Cecilia, what can both, you know, trans folks who are thinking about getting vaccinated do to kind of prepare for that experience, and what can, you know, some of these locations that are vaccinating folks really do to just be more trans and particularly sex worker affirming as well?
Yeah, thank you for that. Well, unfortunately, you know, as trans people, it's not something new for us. Usually, sexual health has been overwhelmingly overtaken by gay men, usually, and like the response has been oriented to that narrative. So, you know, trans people unfortunately aren't, you know, used to these. So what I can say is like, just like deal with it to the best of your ability. And like, you know, unfortunately for us, sometimes accessing this kind of like sexual health when it comes directly from the government is not something that we can negotiate much. Am I telling you to suck it up? I wish I didn't have to, but unfortunately, at this moment, is the best thing that we can do. You know, and like try to get your vaccine, try to get over it, you know, and get it done. Unfortunately, at this moment, I don't think we have the luxury to kind of like say like, oh, I'm not gonna do this until they don't ask me these intrusive questions. You know, it's either that and not getting the vaccine, or getting the vaccine. And if this is something that affects you in a great way, you know, you should always try to get vaccinated at all costs. And it pains me to say this, right? And just, you know, making sure that you know, you like you said, Emmett, you know, I'm not against lying. You know, if you have to lie to get your vaccine, just lie away. You know, I don't care. As long as you get your vaccine, you know what you need and you know what's necessary for you, right? So it is important that, you know, that everybody that has an opportunity to get the vaccine gets it. I also wanted to mention a little bit for people that for me, sex is. Sorry, I talked too fast. I see Corina going like, oh, sorry, Corina. You know, for folks for whom sex is their job, is what they do for living. Please try to make it, again, whatever you have to answer, be creative in order to accommodate yourself to those answers so you can get your vaccines. Very, very important. Consider virtual sessions or coming if you can. You know, let's remember there's other ways to make money with the idea of being sexual instead of like encounters. You know, and of course that's not something that is available to everybody easily. But if you have an opportunity to move into an OnlyFans or to come in or to phone sex is back, you all. People consume phone sex a lot. Doesn't do it for me, but for many people it does. And so make your money with phone sex, right? And if you need to keep seeing clients, just make sure that you change your sheets or put towels in between clients, and that you wash those sheets or those towels in a very, very high heat. If you have a rash or any kind of lessons, you know, but unfortunately you need to keep seeing clients, cover your rash or your bumps with clothes. You know, one part of sex work is that we can be very inventive on how we define sexy. So we try to cover with band-aids and try to avoid skin-to-skin contact to the most possible. As a sex worker, I know how to bullshit my way around to make a person feel happy with my service and also do the minimum possible. So try to avoid skin contact. If you see a person with any kind of bumps, make a decision and say like, hey, I don't think I can do this right now. But if you need the money, just try to avoid any kind of skin contact and kissing. Yeah, avoid kissing to the most possible. And you know, if you do have any MPP symptoms, like you know, try to rest, hydrate, and try to see if it can go right.
Thank you, Cecilia. I think that kind of harm reduction, I think it is possible when there isn't that, you know, when we aren't able to have financial support, many of us can't stay at home during that isolation period. Oliver, I do see your hand is up. Did you want to jump in on something here?
Yeah, in terms of, I love Cecilia's recommendations, every one of them. If you live in a place that does not consider being a sex worker or being a trans person as being eligible for the vaccine, the best lie you can tell is someone I had sex with 5 days ago or 4 days ago just has monkeypox. Just call yourself a contact to a known or suspected case. I cannot think of a jurisdiction that won't vaccinate you. And as far as I'm concerned, that is a more than acceptable shading of the truth, because who knows, maybe you did have sex with someone who has monkeypox. Okay.
Yeah.
We're lucky in San Francisco, sex workers and are considered high risk for disease and are vaccinated, but not every place does that.
Yeah, and I see folks in the Q&A also talking about folks experiencing homelessness. You know, Cecilia and I, when we talked yesterday, it was anyone who experiences any type of health disparity, you know, may be on the lookout for eligibility criteria to change in your area. And that's kind of what I would say is, you know, if you haven't been eligible so far, eligibility criteria is going to keep changing. The best place you can look for that is on your state or local health department website. And then one thing before I kind of move us into wrapping up is, you know, Cecilia, you know, I think that there's definitely, you said this yesterday was, you know, if you haven't been involved in your healthcare, you haven't, you know, if you've been mistreated in, you know, in sexual healthcare or any sort of other healthcare and it feels really daunting, you know, there are ways to get support through that. I think of, you know, trans buddy programs, you know, something that I kind of grew up with, where, you know, you have someone come with you just in case there's any issues so that they can witness it, you can advocate. If you're immunocompromised or older, you may also be eligible for those reasons and those reasons alone, as well as others. But just definitely making sure that there's somebody that you can talk to. And I know that the Coin Clinic at Callen Lorde is kind of being one of those conduits specifically for sex workers to get them connected to treatment and vaccines.
We have been doing a lot of work on connecting folks to the vaccines, but I also wanted to remind folks that it's very important that we all, if we have an opportunity, and we can engage in advocacy, right? Because of course, like this is important to take like a direct approach, like getting a vaccine or helping somebody get a vaccine, right? But it is a micro level of work that needs to be done that has to do with advocacy, that has to do with engaging with advocates trying to get better health and sexual health for everybody that needs it.
Definitely. All right, so I know we have a hard stop at the moment. Again, thank you everyone for your patience with our technical issues earlier. As we said earlier, we'll be answering questions we didn't get to. I know that there were quite a few questions about internal scarring that we would like to get answered. And those will be available after this call. I'm sorry, after this webinar is posted. So give us a little bit of time. And then Julio, I'll throw it back to you to just close this out.
I just want to say, first and foremost, thank you to our incredible panelists. Thank you everyone again for your patience. Technology was not 100% on our side today, but we were able to bring some incredible information. We will get those answers to folks. And I know that we have conversations about how we can replicate this type of format as you know, there may be more twists and turns in terms of how this health crisis presents itself and how you know, treatment and prevention strategies may shift and change. So definitely stay tuned because AIDS United and Building Healthy Online Communities have a commitment to ensuring that we get all kinds of great information about this out. So thank you. Thank you to my partners at BHOC.
Thanks, everyone. Have a great day.
Thanks, this was great.